Madam, we are live now, so we are starting the program. So, good evening, doctors and all the participants. Shuman, on behalf of Shade Healthcare, welcome you all in today's very important and interesting session with Dr. Kavita Bapat ma'am in association with Uttarakhand Society of Obstetrician and Gynecologists, along with Dehradun, Handwani, Haridwar, Rudrapur, Roorkee, and Kashipur societies in organizing this webinar. And the topic of the program is acute abdomen in pregnancy. So, now it's time to introduce our conveners and Dr. Archana Singh ma'am. It's my honor to introduce madam. Madam is the senior consultant OBGN in Siddhi Vinayak Hospital, Haldwani. And Madam did her MBBS, MS, FMS and PGD, and she is presently the Secretary of Uttarakhand Society of Obstetricians and Gynecologists. So with this short introduction, I request Madam to take over the session for further.
Thank you.
Thank you very much and over to you.
Thank you so much. And on the behalf of Uttarakhand Society, I welcome all to this webinar. All the delegates are definitely, without them, the webinar cannot be a possibility. So today, we have a very demanding topic, that is acute abdominal pregnancy. And with great honor and pleasure, we have the privilege to have Dr. Kavita Bapat ma'am, who I think all the gynecologists all over India know her. And she will be giving us very practical tips to how to deal with acute abdominal pregnancy. Along with her, we have Dr. Brijbala ma'am, who is President Indore Gynae Obstetrician Society. So I would request Dr. Meenu ma'am to please introduce Dr. Kavita Bapat ma'am and welcome our delegates.
Good evening, everyone. At the outset, I thank Dr. Kavita Bapat ma'am for introducing about this topic and putting this topic forward that we should discuss about this topic. I thank you very much, Dr. Kavita Bapat ma'am. And I welcome all my seniors, all my friends, all my colleagues, and all the young brigade which have joined today, which have joined as a panelist and as a delegates also. I welcome you all. I welcome our patron, Dr. Jaideep Malhotra, Dr. Jyoti Sharma, and Dr. Kavita Bapat, who is here. She is the Vice President, West Zone. So I welcome all the presidents of Uttarakhand Society, all the presidents of Dehradun Society, Dr. Manisha, Dr. Anupama from Rudrapur, Dr. Rashmi Sani from Roorkee, Dr. Sangeeta Singhal from Haridwar, and Dr. Jashri from Haldwani, and Dr. Archana Chauhan from Kashipur. I welcome all the secretaries, Dr. Anshu Kakkar, Dr. Anushri Pal, Dr. Sonam Jain, Dr. Pawan Preet Gill, Dr. Anshu Kakkar, Dr. Anushri, Dr. Sujata Pradhan. She is the secretary of Haridwar Society, but she is not participating in panel because of some reason. Dr. Pawanpreet, Dr. Savita Gothi, Secretary Roorkee, and I also welcome Dr. Reena, Dr. Josna, and Dr. Sonu Rao. And I heartwarming welcome to Dr. Brijbala. Dr. Brijbala is a guest to this webinar, and she'll be the expert of the panel. And now I request to put the CV of Dr. Jaideep Malhotra. So Dr. Jaideep Malhotra is the patron of Uttarakhand Society. She is the managing director of ART Rainbow IVF, and she is the chair FIGO REI committee, and she is the president of perinatology committee. And next, she has sent her blessings to us. She is not able to join this webinar. Our next patron is Dr. Jyoti Sharma ma'am. Dr. Jyoti Sharma is a great mentor in a guiding force behind us. She is the practicing gynecologist in Dehradun since 1980. She is the past president of Dehradun and Obstetrician Gynae Society. She has got many awards and applause in her credit. And Dr. Jyoti is here to say a few words. Over to Dr. Jyoti Sharma ma'am. Dr. Jyoti ma'am, I'll call her. I think Dr. Radhika.
मैम जब आएंगी तो
मैम आगे बढ़ जाते हैं.
Ma'am आएंगी तो she'll speak few words. So with these words, we will start our webinar, and the topic, as Dr. Archana has already spoken, is a very important topic. It is a Pandora box, and whenever such patients comes to our clinic, we don't know. It is very challenging situation for diagnostic point of view and the management point of view. There's so many changes occurs during pregnancy. So Dr. Kavita Bapat has taken the pledge to teach us all. So over to Dr. Archana.
Thank you so much, ma'am. Starting with the session 1, which will be a talk by Dr. Kavita Bapat on acute abdominal pregnancy, which will be chaired by Dr. Jayashree Tiwari, who is President Halwani Obs and Gynae Society, Dr. Anupma Ravi Futela, who is President Rudhpur Obs and Gynae Society, and Dr. Manisha Singh, who is President Dehradun Obs and Gynae Society. So I would request Dr. Jayashree ma'am to please introduce our speaker, Dr. Kavita Bapat, and Dr. Anupma ma'am. After that, please give a short introduction about the topic.
Hello. Hello. Am I Jayashree?
Yes, ma'am. Jayashree ma'am, please.
Good afternoon, everyone. And thank you for kind introduction. I welcome you all in this important academic session for today. And Dr. Kavita Bapat, she needs no introduction. Everybody knows her. And her academic session is very long. She was Vice President Foxy 2021 to 22. This time she is a director of Bapat Hospital Indore. She is organizing secretary AICOG 2022 Indore. Everybody knows about this.
Jayashree, bas ek do line aur.
Okay, she is restless in one day, distract me.
मैम लास्ट लाइन पढ़ दीजिए. एविड डॉग लवर के आगे क्या लिखा है?
Okay. She is a post governing counseling member ICOG, and she is a president of Indore Menopause Society this time. She is vice president of MP chapter on vaginal surgery, member of Urogynecological Committee 2022 to 24, executive member ISAR and IAG. So she is her academic and dynamic everything. She's
so
unexplained.
Thank you.
So,
Ma'am, she is coolest grandmother.
Yes, actually, अब मैं यही लाइन पढ़ना चाह रही थी.
Yes.
सबसे बढ़िया. किसी के सीवी में इतनी अच्छी लाइन नहीं मेरे को आज तक दी. Coolest granny. And sari lover, you know.
And sari lover.
Most of us are sari lovers, you know. लेकिन हमने कभी इस बात को flaunt नहीं किया.
I know. हमने चला दिया इसको. And the most important, faith in God. Am I right? Which all we have. So allow me to share my screen. Such as this topic is not so.
Sari lover. That is for sure.
Okay,
That's
so
okay.
before
This is
you
not.
are moving, ma'am,
Yes.
मैं एक line मैं भी add कर दूँ.
Yes.
Acute pregnancy, acute abdominal pregnancy. This just gives us such a heart sinking feeling. The topic itself is, you know, so scary, and that was the major reason why most of us are here, and we are looking forward to what Kavita ma'am has to share.
Yes.
And in this modern era of more of ART practice, you know, all of us should remember a few things like heterotopic pregnancies are on rise, and we should always keep that too in mind. And there are many more things which ma'am would share, and I'm sure that we will have a lot of inputs apart from ectopic. The other things which can be there in pregnancy, ma'am will share. And I'm actually looking forward to what all things regarding ovarian torsion or ovarian masses you would want to add. Thank you so much, ma'am. And welcome.
I would like to say a few words about Dr. Kavita Bapat. Kavita Bapat, doctor visited Dehradun, and she was such a nice person and I have ever met. Very down to earth, very approachable person.
Bindas hai, ma'am.
It makes a lot of difference.
Right word. Ma'am, Kavita ma'am, are you around? We can't hear you. She's probably disconnected.
Yes, ma'am. Ma'am disconnected. I hope some network problem.
Okay. So, in acute
ma'am.
dominant pregnancy, I guess there are few things which, before ma'am carries, we should keep in our minds that, you know, we just take it as acute abdomen.
हाँ, मुझे कोई problem नहीं है, but everyone is waiting, ma'am. वो चित्रकला.
Okay, Jyoti ma'am has joined. Okay.
I think she's talking to Dr.
मैम का ना, कविता मैम का सडनली डिस्कनेक्ट हो गया. वो कोशिश कर रही हैं, है ना. एक्चुअली अगर उनका हो जाता है तो अच्छा है, क्योंकि पवनप्रीत भी अभी टाइम ले रही है, कह रही है वो कुछ ऑपरेशन कर रही है. तो वी कैन स्टार्ट. मैम
Ma'am, I am here.
Oh, you are here. Great. You are very very fast.
घर जा रही हूँ, आ गई मैं.
So ma'am is able to connect, I think.
तो फिर पैनल ही शुरू कर लेते हैं acute abdomen.
We can wait for another. चित्रकला, please look into the matter.
ऐसे हो जाएगा, ऐसी कोई बड़ी बात नहीं.
हाँ, हो जाना चाहिए.
तब तक ज्योति मैम आ गए. मैम से let her.
Hello ज्योति मैम. Good evening ज्योति मैम. I am not able to see her.
नाम लिखा हुआ श्री मैम का.
ज्योति मैम का नाम तो आ रहा है.
She has joined.
आ गई हैं. आ गई हैं.
Okay. We'll share a small story there. A few years ago, I mean, इतनी एज हो जाने के बाद में भी, I just wanted to share a story. One of my IVF patients, she was a doctor's wife, a pediatrician's wife, and still I wanted to share that I missed her ectopic. Her pregnancy test was positive, and it was a very early, like 1,000 or something HCG was there, and we could not see a gestational sac. And we called her after 2 days, and nothing was seen in the tubes. We specifically looked for that, but after 2 days, she went into shock at her home. Husband was not around at that time. He was on his duty out of station, and the wife fainted in her house, and her Dr. Saab's juniors actually attended on her, and she was diagnosed to have a ruptured ectopic. And it's such a common thing that you should always one should keep in mind that even after IVF, we think that we are putting the embryos in the uterine cavity, but still so very common that the embryo somehow लुढ़कता पुढ़कता वो ट्यूब में पहुंच जाता है, and ectopics can happen. So we should always keep that in mind, that ectopics, even though you are very vigilant, can still happen. And
this thing happened.
Is important.
One of our doctor's daughter-in-law, she was a doctor, and she was visiting a gynecologist, and ectopic could not be diagnosed. It was in the isthmus area, and she died.
It's very sad.
There was no bleeding, nothing.
First year
pregnancy test was negative.
I remember in our first year MBBS, the first lecture which we were given in anatomy department, and our seniors were talking about ectopic pregnancy at that time, that young girl, ectopic something. We never realized the importance of how important you should always take every female patient as a pregnant patient, everything. Exactly. You know, he was so adamant on it, and at that time we never realized how important this history taking place.
Very true.
I remember a patient, I had done her IVF, and it was third cycle. Previous 2 were failed cycle somewhere, and it was her second marriage with after tubectomy. So she came positive. We had 3 embryos. She was very much behind. Madam, tino dal di, and on 6 weeks we found 2 intrauterine pregnancy. She was very happy. I am going to deliver 2 babies and all that. Suddenly, she was from some rural area. Suddenly, after 3 weeks, around 9 weeks, she called me, I'm having severe pain. So we used to write ki Drotin le lena. She took Drotin. Usse aaram nahi hua. Then we called her. She came back. There were 2 intrauterine and 1 tubal pregnancy. So heterotropic pregnancy is really common if we are putting 2-3 embryos. Nowadays, we are not doing this, but long 10-year back, we were used to put 2-3 embryos. So it is always ectopic.
Similar experience I had when I started my IVF this thing in 2012. And she conceived after IVF, again the same thing, 3 embryos we put. And the titer was, beta HCG was very high. And again, I told her you might have twin pregnancy because the titers are very high. And we did ultrasound, we found one sac. And I never thought it could be another, there was some mass growing up. So we thought it must be some corpus luteum, something ovarian cyst-like because of the unutilized follicle which is lying there, corpus luteum. And she was complaining, pain, and titer were rising. And then we did ultrasound after 1 week and there was cardiac activity in the sac. So these things do occur. do occur sometime.
Ma'am, I had a patient in spontaneous conception long time back. She came in shock. We managed her as ectopic, and baad mein intrauterine also popped up.
Okay.
So it was reverse heterotropic that time. That was a spontaneous conception.
Dr. Kavita Bapat, she's staying nearby my house. So there is some issue in electricity. So she's asking us to start with the panel.
Okay, we will start the panel. Okay,
Jyoti
sure.
Ma'am, she has joined.
Dr. Jyoti ma'am. Jyoti ma'am is here.
Yes, ma'am.
Jyoti ma'am, say a few words.
Hello, ma'am. Yes, ma'am is here. Ma'am, you are muted. Ma'am, you are muted.
ज्योति मैम आप muted हैं.
मैम muted हो आप. मैम आप unmute कर लो.
Now can you hear me?
Yes, we can hear you.
Okay. Anyway, the topic for today is a very, very interesting topic because this is something I think each one of us must be facing. Acute pain in pregnancy. And there was in fact, about a few months back, there was a case. She was an unmarried girl. She came with pain in abdomen and maybe urinary tract infection with proper history, because in an unmarried girl, it is, we normally don't even sort of opt to do a vaginal examination. But on ultrasound, there was some adnexal mass. So we got a pregnancy test done and it was positive. And it turned out to be an ectopic pregnancy with a live this thing. So, this, we have to think about acute abdomen with or with a period of amenorrhea, slight irregular bleeding, about ectopics, because having a living in relationship these days is not a very uncommon thing. It's quite common to find women with living in relationship. And, if we miss them, then and we send them home, it might just land up to a great disaster. So, another case recently operated by us she was a case of an intrauterine pregnancy, and we saw her at about 6 weeks or so with hyperemesis. Then she came just about 10 days back with acute pain in abdomen. And at the first scan, there was a small cyst in the right ovary. And this time when she came about 10 days back with acute pain in abdomen and again excessive hyperemesis gravidarum. And when we did an ultrasound, there was a double twisted torsion of the ovarian cyst. And when we opened her, there was no vascularity, just falling short of gangrene of that particular. So maybe persistent vomiting and excessive vomiting led to torsion of that particular cyst. So these things, I think we all of us are facing them now and then. Appendix can be a cause. Acute urinary tract infection can be a cause. A stone, a ureteric stone, or even sort of acute sigmoidal sort of infections. So this is a very important topic, and I am so happy that this has come up in our routine discussions, and it is going to be of a great help to everybody who's listening to this particular subject. And Meenu, I wish you all the best. You come up with such lovely topics, not just the routine, repeated pregnancy losses, endometriosis. And these are acute pain in abdomen can be such a vast subject. I mean, like it's a magic box. And I'm sure everyone who's listening to this particular episode of this particular scientific session is going to go back more, कुछ सीख के ही जाएगा यहाँ से. Thank you so much. Thank you. I think we should start with our scientific session.
Thank you, ma'am. Thank you, ma'am. Thank you, ma'am, for insights and pearls of wisdom.
Thank you.
So I think we should start with a panel now. And this panel will be moderated by Dr. Veenu Vash ma'am, who is President, Uttarakhand Obs and Gynae Society. And we have a panel expert in form of Dr. Brijbala Tiwari, who is President, Indore OB-GYN Society. So, and we have got very learned panelists. So this will be very interesting. The chairpersons for this panel are Dr. Reena Shingal, who is President, Kashipur Obs and Gynae Society, Dr. Sanjana Shingal, President, Haridwar OB-GYN Society, and Dr. Rashmi Saini, President, Turkey OB-GYN Society. So I now request Dr. Rashmi Saini, ma'am, to please introduce Dr. Veenu Vash in short.
Good evening, everyone. It is a great pleasure to me to introduce Dr. Veenu Vash. Dr. Veenu Vash is a co-founder of Mehar Hospital, Dehradun. She is a skilled and caring obstetrician and gynecologist working in Dehradun for last 3 decades. She received her MBBS degree from
only 2 lines.
Okay, ma'am. At present, she has served as a president of the Uttarakhand Society of Obs and Gynae. Madam got the Medical Excellence Award by the Chief Minister of Uttarakhand in 2018. She has repute of being the best doctor award by the Uttarakhand Mahila Association.
I think, Rashmi, it is enough.
Okay,
thank you.
I would request Dr. Reena Shingal ma'am to please introduce Dr. Brijbala ma'am.
Voice is not coming.
Hello.
Yeah, ma'am, you're audible.
Okay. Good evening, everyone. This is my pleasure. Dr. Brijbala Tiwari is President of Indore OBGY Society, and she is Vice President of IMA Indore branch and Indore Menopause chapter. She worked as Joint Secretary of MPIS AR in year 2020-22 and Secretary IOGS in 2016 and 17. She has organized many live surgical workshops and faculty in national and international conferences, and she is the recipient of C.S. John Best Paper Award in AICOG 2014. She is a consultant gynecologist and infertility specialist running a Life Care Hospital. She is managing director of Life Care Hospital and Santati Infertility Test Tube Baby Center. I welcome Dr. Brijbala at this platform. Thank you.
Over to Meenu ma'am.
Thank you, Meenu ma'am.
Meenu ma'am, please continue with your panel. No, Meenu ma'am. Ma'am, you're muted. Veenu Vash ma'am. Yes, ma'am.
Okay. These are my panelists. So thank you, Dr. Rashmi, for lovely words. And thank you, Dr. Reena, for introducing Dr. Brijbala. She'll be the panel experts in our panel. We have got brigade of young doctors as a panelist. They are very intelligent, they are very enthusiastic and knowledgeable. And we have arranged them alphabetically as a question wise also. And they can answer any question. So we have Dr. Anshu Kakkar, Secretary, Dehradun Obs and Gynae Society. She is running maternity and eye hospital. We have Dr. Sonu Raut, President Haridwar Obs and Gynae Society. She is the past secretary. And Dr. Sonam, she is the past secretary, Kashipur Society, Dr. Pawan Preet. She's the founder president of the Rudrapur Obs and Gynae Society, and she at present secretary of Rudrapur Obs and Gynae Society. Dr. Joshna Agarwal, past secretary, Roorkee Obs and Gynae Society, and she is very much academically oriented. And Dr. Anushri Pal, she is the secretary, Haldwani Obs and Gynae Society. So we'll be starting our panel. We all know we wanted to listen to Dr. Kavita Bapat first, then our panel would have become easier. Anyway, we will start our panel.
Ma'am, 1 second. मैं founder president नहीं हूँ. Founder president is Anupama madam.
No, you are the founder secretary, my dear. You are the founder secretary. Am I right? Am I right?
Hey, sorry, extremely.
Yes, sir. Yeah.
Extremely sorry.
Founder and permanent secretary.
Yeah, that's a good thing. I came to know from Dr. Ashna.
And Dr. Kavita has joined.
Hey, शुरू करें क्या?
Yes, ma'am.
Sorry, यार. Allow me to share the screen.
Okay, ma'am. You start, then our panel will become easier.
I know that. मेरे भी दिल में वही था कि मैं कुछ बोलूं तो उसके बाद आप लोग बोलो तो इतनी बड़ी आग लगी कि क्या ही बताएं, बदतमीजियों जैसी. See, the life में कुछ भी हो सकता है. I'm telling you. Share. Allow me to share the screen. I won't take much time. I'll make it fast. So thank you so much. And I come from Indore. I'm really happy whenever I talk about it and do everything. So again, the acute abdomen of the pregnancy. So we'll just do 3-4 cases and we'll talk about it and we'll discuss. Meenu, I'm extremely sorry for my bad behavior, or you can say the worst behavior, because बहुत जोर से
you are absolutely right, ma'am. We love you from the core of our heart.
Yeah. So the case 1 is 29-year-old, pregnant at 33 weeks, gestational presence. Decision presents into the emergency department with sudden onset of severe abdominal pain. And that started only 2 hours ago. She described that pain was a constant, sharp, and located at the upper right quadrant of her abdomen. She also reports that the nausea, vomiting, fever, but she denies the vaginal bleeding, any discharge. And she has a history of gestational diabetes, she has a history of hypertension, and she has a history of previous cesarean section. So whenever we talk about the cases like acute abdomen in pregnancy, this type of patients, basically, we are worried about either this is because of the obstetric cause or it's because of the non-obstetric cause. We just make it in a 2 different era we should talk about. Then the physical examination appears uncomfortable, lying in the bed with her knees bent. Another important point. Vital signs within normal lipids, elevated temperature, simply 38.3. Abdomen tender, palpation on the right upper quadrant. There is a rebound tenderness. Uterus palpable and tender. Fetal heart rate monitoring shows reassuring pattern with no signs of distress. So simple things, simple points are there. Now the diagnostic test, a complete blood count was done and it was found a leukocytosis with a white cell blood count is 15,000. Liver function test, it's an elevated one. An ultrasound of the abdomen showed the enlarged, inflamed gallbladder with a pericholecystic fluid. The common bile duct is not dilated. There is no signs of placental abruption or the fetal distress. Now, the diagnosis is acute cholecystitis in pregnancy. Management admitted to the hospital for observation, antibiotics given for the infection, kept nil by mouth to rest her digestive system, intravenous fluid to maintain hydration, pain management done, patient counseled on the need for the close fetal monitoring. After stabilization, she is taken for the surgery for laparoscopic cholecystectomy. So, and the things are very, very. So, what is the outcome? Successfully undergone the surgery without complication, discharged home post-operatively day 3, regular follow-up visits with her obstetrician, and delivers a healthy baby at 37-week gestation by scheduled repeat cesarean section. This is the case 1. Now the case 2, 27-year-old, 28 weeks of gestation, Emergency department complaining of severe abdominal pain, vomiting for the last 12 hours, also reports fevers and chills. History, pregnancy has been unremarkable, regular antenatal checkups, ultrasound during the pregnancy showing healthy fetus, has a no significant medical or surgical history, and examination revealed she is a pale, she is in a severe distress, lying on her back, again knees bent, because the pain is so much with acute abdomen, the patient comes with a knees bent. And the vital signs, temperature 38.5, heart rate is little higher, 110, respiratory rate normal 20, blood pressure normal, abdomen distended, tense, tender with rebounded tenderness. Heart sound absent. So the leukocyte, this investigation is done, complete blood count, they came up to 20,000 blood cells, this is count. Urine analysis positive for leukocytes and nitrites. So the diagnosis changes, serum electrolyte, liver function and coagulation profile within normal levels. Obstetric ultrasound shows live fetus in breech presentation and the amniotic induced is reduced. So on the basis of the patient's history, physical examination, investigation and diagnosis, this acute abdominal pregnancy was a suspected pyelonephritis and oligohydramnios. Why pyelonephritis? Because in the urine they have found the keto, the infection also, the nitrate, and she had a history of chills with fever for so many days and a severe pain into the abdomen. And then she was, I'm just sorry. So the diagnosis was made and she was admitted in a hospital, intravenous fluid, broad spectrum antibiotics, infection for the intra-abdominal infection. Counseled well, management options. She was managed, it was told that you want to terminate the pregnancy or the medical management will do. After thorough discussion about the risk and the benefits of each option, she opts for the medical management. She doesn't say that I don't want my baby to be terminated and you continue the treatment with a medical thing. Then further investigations done, blood culture, urine culture, abdominal and pelvic ultrasound are done. Blood culture shows Escherichia coli and urine culture confirms the presence of same organism. She was treated with intravenous antibiotics, antipyretics, analgesics. Obstetric team closely monitored her fetal well-being. Patient was given corticosteroids to promote fetal lung maturation. Her condition improves over next few days and she was discharged from the hospital after 7 days of intravenous antibiotics. And the conclusion again, the acute abdominal pregnancy can have various causes, but prompt and thorough evaluation is necessary to avoid the adverse maternal and fetal outcome. Most important is the early recognition and the management of underlying infection, such as a myelonephritis, is crucial. Sometimes these are the incidences of pyelonephritis or the cholecystitis or other causes are really low, but when the things are in the mind, we are able to diagnose. We should know all those points. So the management option depends upon the underlying pathology, what is the gestational age, and what is the maternal condition. Close monitoring of the fetal being was essential. Timely delivery may be necessary in some cases, and that's all. Now, this is case 3. Is a 36 weeks who presents with the emergency department with a sudden onset of severe abdominal pain and most important, vaginal bleeding. So this is a worrisome for us, for everyone. Abdominal pain and obstetric cause, alarming. Then the pregnancy B has been unremarkable with regular antenatal checkups, ultrasound showing healthy fetus. She has a history of 2 previous vaginal deliveries. Then severe distress, lying on her back, knees bent. Her vital signs show heart rate 120. Respiratory rate is also high, 22. And the blood pressure is normal, though it's a normal 110/70. Abdomen distended, tense, tender with rebound tenderness. Fetal heart sound absent. Complete blood count, leukocytes 12,000. Urine analysis unremarkable. Serum electrolyte, liver function, coagulation profile within normal limits. Obstetric ultrasound shows intrauterine fetal demise with a large amount of free fluid into the abdomen and a pelvis. The diagnosis based on the patient history, physical examination and investigations of acute abdomen in pregnancy with obstetric cause. It can be placental abruption or the uterine rupture is made. So what they did, we just Did the management admit it into hospital? Resuscitation measures started immediately. Intravenous fluid, blood products are needed to correct the hemodynamic instability. Counseled on the management options, which include induction of labor or a surgical delivery. But surgical delivery was very, very important. Induction was not needed over there. Then emergency laparotomy was performed. Ruptured uterus with active bleeding. Ruptured uterus repaired. Stillborn fetus delivered. Lower segment cesarean section. The surgery became complicated by the postpartum hemorrhage, which was managed by the additional blood transfusion, uterine artery embolization, and at the last, hysterectomy being done. And she was transferred to the intensive care unit for further monitoring and management. We have seen this type of cases many times in our life with acute abdomen and all those things. Acute abdomen in pregnancy with the obstetric cause is a catastrophic, placental absorption or uterine rupture, and consequences both mother and the fetus. So we should have always a high index of suspicion is necessary. Prompt and appropriate management is essential. Minimize the morbidity and mortality, and management option again depend upon what is the pathology, what is the gestational age, and what is the maternal condition. Timely resuscitation, surgical intervention, and close monitoring is crucial in these cases. Now the fourth case, the case 3, conclusion, acute abdomen pregnancy with obstetric cause. I think we have gone through. Then the case 4, this is a case 4 is a 28-year-old, 22 years of gestation, presents emergency department with the complaints of sudden onset of severe pain, but she is also having a nausea and vomiting. Then the history, pregnancy was unremarkable, regular antenatal checkups, ultrasound show healthy fetus. History of 1 previous vaginal delivery. Physical examination, severe distress. Vital signs again, more, heart rate is more. This time respiratory rate is more, but the pressure is normal. Abdomen distended, tense, tender, bound tenderness, fetal heart sounds normal. Investigations, complete blood count, 13,000. Urine analysis, unremarkable. Serum electrolyte, liver function, coagulation profile, normal. Obstetric ultrasound show live fetus with a cephalic presentation and normal amniotic fluid. Now the diagnosis, patient history, physical examination, investigation. I am repeating in every case these points: history, examination, investigation, diagnosis. Is we should go in one after one and follow it. With a pregnancy with a non-obstetric causes such as appendicitis, cholecystitis is made. Then the management, admitted in the hospital, IV fluid, broad spectrum antibiotic, possible intra-abdominal infection, counseled on the management options, which made a medical management or a surgical intervention. Further investigations are needed because abdominal pelvic ultrasound and CT scan are done in this case. And CT scan confirms the diagnosis of acute appendicitis with periappendiceal abscess formation. So that this is the difference, though the count was not much, but the rebound tenderness, the localized tenderness, and the history all suggested, and then the role of CT scan has come. The role of CT scan is very, very important in the cases to diagnose and confirm cases of appendicitis, though that's important. Emergency laparoscopic appendectomy done. Surgery went eventual, postoperatively closely monitored for complication, and she was given a prophylactic antibiotic, analgesics, clear fluid diet. Her condition improves next few days. She was discharged from the hospital for 5 days, and she advised to follow up to her obstetrician for other antenatal care. So the conclusion again, when acute abdomen of pregnancy with non-obstetric cases such as appendicitis, cholecystitis is a relatively rare but can have a significant maternal and fetal morbidity and mortality. So we should keep in mind that we should have a high index of suspicion, prompt and appropriate management, and minimize the adverse outcome. We should again, the 4 things are very, very important. What is the underlying pathology? What is the gestational age? What is the maternal condition? And we need a multidisciplinary approach for every case, obstetrician, general surgeon, anesthetist, and ensure the maternal and fetal outcome is very, very important. So just making these 4 cases about the pyelonephritis, cholecystitis, appendicitis, and the rupture of the uterus. I'm not going into the torsion of the ovary or in a ectopic. We are all of us are very smart and diagnosing the ectopic pregnancy. Nice. This is also acute abdomen. So introduction is history taking should be brief, focused, and asked about the underlying medical conditions. Prior surgery, number one, very important. Medications, on any medication she is. What allergies she is having is another important point, and ask her about the pregnancy complication, about vaginal bleeding, leakage of fluid, can be prompt, can have the contraction, she will tell about, and the fetal movements, and the most important are the points. Now on examination, we should consider it's a generalized or a focal tenderness. Is this give the difference thing? If the tenderness is generalized, we should think on a different direction. But if the focal tenderness, we should think on a different direction. Presence or absence of guarding. This is another different thing. See, these are the things when we were undergraduates, we used to do it. But whereas doing the postgraduates and doing so many things, we just forget about the basic things. The presence of the absence of guarding. This indicates we can differentiate from the obstetric and a non-obstetric causes. If there is a guarding, we can think about the non-obstetric causes. If there is no guarding, then nothing is like that. Then rebound tenderness, increased or a decreased bowel movements, again, it's a non-obstetric thing. So we should know about it. Then confirm the gestational age and document the fetal well-being, especially if that's a more than 24 weeks of the gestation. We need not to go in a detail of many more things, but these are the basic things we should know how to examine, and we should know that focal tenderness, what is a guarding, what is a bowel sound, and confirm the gestational age is very, very important. Then the point comes about the white cell count. In normal pregnancy, it is 10 to 14,000, but the white blood cell count may be 20 to 30,000 at term and the labor. So it also gives a wrong information कि किसकी वजह से WBC इतना बढ़ गया है. So that's another important point. So the counts are significantly higher than that of the incidence of the left.
Some internet issue.
Please look into the ma'am's.
Ma'am, I guess ma'am got disconnected again.
Yeah, again disconnected.
मैम को फोन करके प्लीज आप बोल देंगे क्या कुछ प्रॉब्लम है?
I'm asking her. She is not picking phone. She is not picking phone.
She must be handling her this thing connection. So we'll wait.
Ma'am, at 36 weeks, do we normally do laparoscopic procedures like appendectomy?
I think ma'am talked about laparoscopy.
Yeah, 36
we have to
weeks.
take out the baby by cesarean. And
It was 26 weeks.
Lower segment.
No,
and
it was
vertical
36.
incision and
Appendix wala case 36 and that was 33. Cholecystitis wala 33 weeks. So I was just thinking port के लिए जगह कहाँ रहेगी 36 में?
नहीं हो
In the
पाएगी.
lower lateral.
Lower lateral में भी.
I don't think she talked about the laparoscopy.
Laparoscopic, yeah, laparoscopic.
I think at that time, because appendicitis is there and there is so much inflammation, counts is there. So
laparotomy has
take out the
Is it
baby
okay
also
to
and
do
the
CT in pregnancy? CT?
Yeah, ma'am has come. Ma'am has come.
Yeah, I have joined. Okay.
Kavita ma'am, is it okay to have CT in pregnancy?
Great.
आज कुछ गड़बड़ दिन है. I'm really sorry for that. I'm extremely sorry. बहुत उत्तराखंड दूर हो रहा है, जरा पास करना पड़ेगा.
That is the reason. You have to come to Uttarakhand, ma'am.
I will.
Only then you have to deliver your lecture.
I will definitely come. So this is the point. Underlying
Your
infection.
visit to Dehradun was marvelous. Anyways, पढ़ाई की बात करते हैं.
Love you for this. So I'm sorry for the obstruction. Though the acute abdomen of the pregnant, the fast and the smartest and the super fast treatment, but sorry for the obstruction. Probably the differential diagnosis is troubling us. So the acute abdomen in pregnancy, there's a potential different diagnosis. We can have the placental abruption, uterine rupture, preterm labor, ectopic, molar pregnancy, ovarian torsion. I'm just adding one more point. We can have one more thing is there can be a red degeneration of the fibroids, can cause the acute abdomen also. So the placental abruption, we all know we can diagnose by just sonography. Uterine rupture, sometimes not able to diagnose by the thing, but the hemodynamically unstable patient, we end up in the preterm labor, we can diagnose. Ectopic pregnancy, we all are smart. Molar pregnancy, I don't think nowadays we see this type of patient. But previously when we were students, we have seen the molar pregnancy up to 30 weeks and 28 weeks and whatnot. And severe abdominal of the patient and patient used to come. Ovarian torsion is another important point. And IUD may be due to the rupture or without rupture and can end up into the sometimes this. So these are this. And the non-obstetric causes, appendicitis, we have talked about, the guarding, the localized pain, the localized tenderness, acute cholecystitis, right, upper quadrant pain with sonographically we can diagnose. Acute appendicitis is again and again thing. So you had a topic of discussion. कि हमें CT scan MRI करना चाहिए या नहीं करना चाहिए. But I am telling you, if you really want to save yourself medically and clinically, acute appendicitis by sonography, we are not able to, until and unless it's a big appendix and with such a abscess formation or something, it's visible through sonography, which is not. We have to do the CT or MRI. CT scan is the best. And 32, 33, 4 weeks, though they don't allow, but we have to do. Peptic ulcer disease, we can differentiate always. Bowel obstruction is another thing by finding out the thing. Then mesenteric ischemia, I think mesenteric ischemia is not so common, but people like you who are there in a medical colleges or doing so much work, sometimes a mesenteric ischemia case, maybe there I have never seen in my life. Acute diverticulitis, similar like appendicitis. Gastroenteritis, we can differentiate with the history also. Then pyelonephritis, we already talked about. Urinary tract stones, we can diagnose by sonography. Then ruptured ovarian cysts and adnexal torsion, again, we can find it out with it. And trauma. We always take the history of trauma in this country or any other country, but what I mean, but we should know about the trauma is very, very important. And mind it, these disorders we should know, and they can lead to severe abdominal, acute abdomen. Number 1 is a sickle cell crisis. Number 2 is the pneumonia. And number 3 is a diabetic ketoacidosis. So these are though the really rare thing, but they can lead into it. And the 4th one is the porphyria. So mind it, all these 4. Then it is important to note that some conditions can present similarly in the pregnant and non-pregnant patients, while others may present differently due to the anatomical and physiological changes that occur during pregnancy. What is needed? I'm extremely sorry for my behavior today, but by having the shutdown of the light and then reinstall and then again I've gone. The prompt and accurate diagnosis is very important for the management, and a multidisciplinary approach always needed. We need not to feel bad to seek the advices from general surgeon, anesthetists and radiologists, but make it a point that we should also know everything. It should not be like that, अरे पेट में दुख रहा है, इसको तो surgery department में shift कर दो. We should be able to say something so that, because the patient is ours, the obstetric, we as a being obstetricians, we should be able to know everything, and we have done the MBBS also. So we should know the basic knowledge of everything. Then I'm just making a few points of this and not making it a large. Appendicitis, 2nd trimester, make it a point, very, very abdominal. Abdominal pain, nausea and vomiting. So it's not a 1st trimester, most of it. It's a 2nd trimester disease, and make it a point. It's not, I'm not saying in 100%, but the most of the cases. Low grade fever, rebound tenderness, right lower quadrant. Finish. Appendicitis is done. Suspected, patient taken for surgery, appendectomy. Ectopic pregnancy, we all know, 1st trimester, severe abdominal pain, vaginal bleeding, dizziness, tenderness, lower abdomen, ultrasound is the very best thing to diagnose. And ectopic pregnancy is made, laparoscopic self-injectomy, or because she's already, we have to do it, or the methotrexate, whatever the choice made. Acute cholecystitis, mostly in third trimester. Patient is having some associated conditions, mostly with cholecystitis, that she is too fat or diabetic or pregestational. There are other points which we should consider about this thing. Fever, tenderness, right upper quadrant pain. Ultrasound, gallstone, sign of acute cholecystitis, and the patient admitted. Observation, antibiotics, cholecystectomy plan. Maybe after the delivery, if she is being relieved by it, or if not, then remove it during pregnancy, but it depends on ovarian torsion, mostly in second trimester, and then examination, tenderness in the lower abdomen. We can feel the enlarged tender ovary, ultrasound, twisted ovary, decreased blood flow, confirm the diagnosis, patient taken for surgery, oophoropexy or oophorectomy. I think most of us have done this type of surgeries during pregnancy also in a second trimester. Acute pancreatitis is a bad disease, mostly in third trimester. Upper quadrant pain, nausea, maybe having the history of gallstone or the gestational diabetes. Laboratory test, elevated pancreatic enzymes that confirms the diagnosis. Hospitalized, treat, supportive care, pain management, fluid and nutritional support. All these cases, most important, prompt and appropriate management, minimize the risk of both mother and developing fetus. Treatment options depend upon the gestational age, fetus and other factors. Important to seek immediate medical attention. Unusual abdominal pain, discomfort during pregnancy. Now just take home messages at this last few slides of mine and what we learned and what we want to spread the message. I don't like to write nowadays take home message. We are working, so we take work message is I call nowadays. So the number one is a general algorithm of the abdomen. Immediate stabilization, evaluate vital signs, airway, breathing and circulation. Administer, supplement oxygen if needed. Initiate the intravenous access, administer fluid, and if resuscitation is indicated, do it. Consider pain management, antiemetics appropriate. Obstetric evaluation, gestational age, fetal viability, monitor fetal heart contractions, perform pelvic examination to evaluate cervical dilatation, effacement and station, perform transabdominal or transvaginal ultrasound to assess fetal well-being, amniotic fluid volume and a placental location. Non-obstetric evaluation, thorough history, examination, potential non-obstetric causes of the abdomen. We should know, we should have the high suspicion index, and laboratory tests, complete blood count, electrolyte, liver function, coagulation profile, and urine. Imaging studies, abdominal ultrasound, and computer tomography, CT scan, such as indicate. Treatment depends upon the cause and acute prevalence and what is the gestational age. Obstetric causes require immediate delivery or emergency cesarean section. Non-obstetric causes require medical management, antibiotics, analgesic, surgical intervention. Again, should be closely monitored, such as preterm labor, hemorrhage, and infection can happen to the acute abdomen because of non-obstetric causes, can end up into these three things. Post-operative care, monitoring, fetal well-being, appropriate pain management. Patient should be counseled on the potential risk and benefits of the option. Potential is this thing. Then what is the follow-up? Patient should be monitored closely, hospitalization, follow-up visits, obstetrician ensure the appropriate management and monitor the potential complication. We also need long-term follow-ups on the necessary, such as the placental abruption and preterm labor. Important to note that the management of acute abdomen in pregnancy is complex, requires multidisciplinary approach, which we have talked about. Now, this is the last algorithm which I love to talk about. Take a detailed history, perform physical examination, CBC, TND, electrolytes, liver, renal function. Then make it a point, is the patient hemodynamically stable or not stable? So first we'll go with if the patient is not hemodynamically stable, initiate aggressive blood components, urgent surgical anesthesia, FMM consultation. Then continuous fetal heart rate monitoring if viable. Consider immediate exploratory laboratory even in the absence of diagnosis. So make it a point, if the patient is hemodynamically unstable and she is requiring many more things, we need not to confirm sometimes the diagnosis, but to save the patient, exploratory laparotomy is needed. Then if she is stable, then we divide into two parts. Either she is having the lower abdominal pain or she is having the epigastric pain. If the lower abdominal pain, appendicitis, immediately admit. Alternative diagnosis, consider differential. Again, all teams should be there. Urgent surgical consultation, fetal heart rate monitoring and all. We divide it into two parts. If high clinical suspect, clinical index of suspicion, immediate laparotomy, laparoscopy, appendectomy. But if we think there is an intermediate clinical index of suspicion, opt in abdomen ultrasound, suggestive appendicitis, do it. If not, it's equal, opt in abdominal MR or CT. And again, if it's suggestive, go for the surgery. If it is not, then continue expectant management, abdominal examination, empirical antibiotics, monitoring, and contractions. This is a great difference between the two, the lower abdominal pain and the epigastric pain. If there is epigastric pain, think about the biliary disease. Again, same thing, admit, give the diagnosis, general consultation, imaging studies, find it out, supportive care, hydration, pain control. Patient is improving clinically, then do these three things. Serial abdominal examination, empiric antibiotics, and this thing. But if the patient is not improving, urgent surgical intervention, consider antenatal steroids, and proceed with the delivery of usual obstetric indication. Thank you so much. We should think differently when the point comes of the acute abdomen of the pregnancy. Thank you so much for inviting me and make me a part of everything. Thank you so much. Oh, I'm extremely sorry for my bad behavior.
Beautiful, 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 very beautiful presentation.
Wonderful.
Now it has become easier for all of us. And thank you, Dr. Kavita. You shared few slides to me, and that
it's yours.
I learned
whenever you want, it's yours.
Yeah.
Most of the time they are on the YouTube, so you can get it from there.
That's yeah.
That's
great. Excuse me, ma'am. I would like to add. Excuse me, ma'am. I would like to add 2 points here.
Yes, again.
Ma'am, there was one case of this suspected ectopic pregnancy. That was the time when we did not have TVS facility prevalent in our setup. So, suspecting the ectopic pregnancy, we monitored the case, but the pain did not subside. The laparotomy was done, and she came out to be the case of worm infestation. There was a Escherichiasis.
I know.
And the intestine was with the Escherichiasis. And the patient had intrauterine pregnancy, which was not diagnosed on ultrasound also, because it was 4 or 5 weeks pregnancy. So that was the one diagnosis we had in our this experience.
कुछ बोलते हैं ना बायोमा कुछ बोलते हैं जो सब बोला
हाँ वो Escherichiasis का तो she was given.
I don't know.
So that was one case of acute abdomen for that laparotomy was done. And another case was that right hypochondrium was very tender. We admitted the patient and we observed next day there was some vesicles, and she came out to be the herpes zoster case. And she had severe pain in right hypochondrium in a single band of abdomen. I mean, suspected to be the cholecystitis, but there was no gallstone and all. But we admitted the patient, and next day we observed there were small vesicles, and they increases by the time the evening round there. So she was the herpes zoster admitted as acute abdomen.
Correct. So I think most of us have seen the cases of ectopic more. We see rupture. I don't think nowadays we see rupture uterus. Anybody nowadays rupture uterus? I don't think so. When we were students, we used to see the rupture uterus. And most of the time we were unable to diagnose.
It is most of the time it is diagnosed on table.
I know what used to do. So sad. No
nowadays we can diagnose with good sonography.
No ultrasound. For ectopic also we used to do just put a speculum and we put a needle into the colpotomy, and if the blood is there, we used to say ki chalo ectopic hai, ab isko khulwao. I'm telling you. Or the point is very simple. If the patient is hemodynamically unstable, it's our responsibility, irrespective if we are not able to resuscitate the patient, laparotomy is must. Because sometimes, it can be ectopic rupture, can be the torsion, can be the adnexal mass, can be the different things which you talked about. And the non-obstetric causes are, though they look simple, but I'm sure to counsel the patient, to treat them, and all the burden on our mind that how this pregnancy will end up. Means we are worried about the preterm labor, we are worried about the hemorrhage, we are worried about all many things. Stillbirths. One of the reasons is the acute abdominal pregnancy, because of other cause, can end up into the stillbirth, and we are unable to explain to the patient what exactly that. So thank you so much.
Excuse me, ma'am, whose call should it be to do an exploratory laparotomy in a patient of non-obstetric cause? For example, we find that the patient is not responding, and the surgeon should be convinced enough to do a laparotomy because if the diagnosis is not made?
So no, it's a very important thing that how and which type of the place people are working. Am I right?
Yes,
the tertiary and the referral place, there you can end up in it's a small place and you are doing something like acute abdomen. If the patient is hemodynamically stable, you can wait and watch. But if the patient is not hemodynamically stable, better to refer to some tertiary places, and we should have all the people around us. We cannot leave this type of patient, and they can sue us for anything. So make the difference between the two things: hemodynamically stable patient or unstable patient. If unstable patient, start resuscitation. If you are in a right place, refer it to the right place, get all the team and do the rest of the things. This will save you more rather than doing something at your own, if the place is a small. I think Sonu, I think I
yes, ma'am. Yes, ma'am. Thank you, ma'am. I was just saying that if the surgeon denies to do an exploratory laparotomy and we feel that the patient should undergo a laparotomy, the problem there comes that whether, whose calls it should be. He is saying that I do not find that the patient should undergo a laparotomy. We think, no, there is no obstetrical cause, but we think we have to find out. So,
see, the patient is ours. ये सर्जन नहीं मान रहा है तो दूसरा बुला भाई
we have to call surgeon. The requirement is there.
अपनी बात ही नहीं सुन रहा है, ऐसा भी क्या ही सर्जन है यार. We always need a team of our choices. I think everybody will agree कि अपन pediatrician भी उसी को बुलाते हैं, anesthetist भी उसी को बुलाते हैं जो अपने को जमता है.
मैम मेरा ये ऑब्जर्वेशन है, जब रात के 2 बज रहे होते हैं और कुछ इमरजेंसी होती है, सबसे ज्यादा ऑब्स्टेटिशियन की बचती है. बाकी सब कहते हैं अभी रुक जाइए मैडम, 4 घंटे और देख लीजिए, अभी रहने दीजिए. तो
but the decision taking, we have a better decision taking power.
Yeah, ma'am, I agree to that.
At any day we are able to take more decisions. I think any concluding remarks, right from Anupama to Jyotsna to Anushri, anybody? I think
Manisha will add.
Manisha, are you here?
Yes, ma'am.
Manisha का मेरे जैसा इंटरनेट हो रहा है.
Thank you, Kavita ji.
Hi, Manisha.
Hello, ma'am. बहुत ही बढ़िया, wonderful presentation. छोड़ा नहीं, आपने सब कुछ पढ़ा दिया. जनरल मेडिसिन, MBBS सब याद हो गया दोबारा से रिवाइज. जो भूल गए थे. It was just 1-2 questions. वक्त नहीं था. We had how the case at advanced pregnancy was managed laparoscopically, the appendicectomy and all.
Normally the appendectomy, normally it is most second trimester problems, and most of the time we have to conservative treatment. See, it's not that again and again I'm talking the two things. If the patient is hemodynamically stable, and we can make the patients more and more to put out delivery के बाद after obstetric अपना हो जाए उसका, मतलब after delivering the baby, if we are able to, so we are postponing it will be better. But sometimes it becomes emergency. We are in our country, we don't do after 33-34 weeks की कोई scope डाल के cholecystectomy करनी पड़े और appendectomy. It's a rare occasion, and otherwise also these two things are very rare. I'm sure यहाँ जितने लोग बैठे होंगे, I must have seen this type of cases 1% or a 2%. It's not a common entry. It's not a common entry. But it's a theoretically, and it's a good case. It's like with all the facilities and everything available, up to 33 weeks, we can do the cholecystectomy, we can do the.
Ma'am, for 36 weeks, you can deliver the baby also, no? If appendix.
Yeah, that's what decisions should be taken. That's the counseling is needed. Either we should continue with the medical management or we should for the baby. And what is the best for the patient, which should. Because unnecessarily putting a baby in an ICU is also troublesome. So instead of some medical management of that particular disease and prolong the duration of the pregnancy, and things can be.
Yes, cholecystitis quite a few times. If it is bad, intractable pain, they do try stenting also in case there is an obstruction. ERCP and all, they do try if you have intractable pain, so that you can tide over the time of pregnancy, and then after the delivery you can do the definitive procedure.
Definitely.
And
What about the use of CT scan in advanced pregnancy? Are we allowed, or how are we medico-legally?
Yeah, it's a similar like previously when we were students, X-ray karte the at the term of the life. Scan is just like radiological intervention, but this is it's hardly needed somewhere. It is hardly needed, but in a rare case, CT scan is indicated for diagnosis. Sometimes the obstetric, sometimes the appendix, sometimes the diverticulitis. They need to diagnose through, because sonography nahi diagnose kar pa raha hai, and we are patient is stable, and we are not going to open for every patient, no. We are not going to open every patient to see what is the thing is, or putting a laparoscope is not fun. So CT scan is medico-legally advisable, and uski guidelines bhi hai. There is so many green top guidelines and many guidelines are there. It suggests we can do the CT scan during pregnancy.
Ma'am, MRI won't suffix. CT or MRI mein to why don't we do MRI, non-radiation?
This organ is better seen in CT.
No, that is okay, but in pregnancy, we would like to go for MRI rather than going for CT.
MRI करके तुझे दिखा नहीं तो क्या ही कर लेंगे ना, तो अल्ट्रासाउंड से भी काम चल रहा होता तो मैं चला लेती थी ना. Why especially we am talking about CT, no? Otherwise MRI तो am I right? Because when we want to make a particular and sure diagnosis of appendicitis, the CT scan is one of the modalities.
MRI is a better option, no doubt.
So we don't want inconclusive methodology of diagnosing. So if we are ordering a test, we should be very sure that we are going to get a result and our treatment will be very well guided.
MRI will not make this point with appendicitis.
Yes.
CT will.
Ma'am, MRI will pick.
I agree with
MRI,
you.
MRI has even better sensitivity and specificity as compared to CT. But then, ma'am, it is not readily available everywhere.
Yes.
That is the reason that they have advised
interpretation.
That, and for CT,
when diagnosis is inconclusive,
it has to be a limited.
Kavita wants to say, when diagnosis is inconclusive, then we need to switch over to MRI. Otherwise, ultrasound is good enough.
Ultrasound and CT in case of bowel involvement when we are looking at. Thank you, Kavita ji.
Thank you so much.
It was a wonderful presentation. And when are you coming to Dehradun? Looking forward to seeing you at the talk.
I love you for that. I will definitely come. I will definitely.
Thank you.
Such a nice and warm,
Thank you, ma'am.
nice and warm welcome and tolerance by you all, by my non-showing off in between. So extremely sorry for that, my behavior. And thank you so much for being with us.
Thank you, Dr. Kavita.
I am there
for elaborate and very lucid and very impressive. And you have explained everything. And you have solved all the queries.
Thank you so much. Now you do your panel discussion. I am there.
Panel, I think you have covered everything. Nothing is left in the panel. And many slides Dr. Kavita guided me. So, thank you very much, Dr. Kavita.
Take the opinion of all the panelists.
Let us take the opinion of all the panelists.
Yeah, they are
true, Dr. Kavita. Okay, let us start our panel.
Dr. Kavita.
Are you able to see my screen?
Yes, ma'am.
Yes, ma'am.
Yes.
Put on slideshow, ma'am.
Yeah. Slideshow, my computer is not showing the slideshow. Thanks. Anyways, we will start. Dr. Kavita has told everything. We have got a good number of panelists and we'll see. And we have, as Dr. Kavita, anything can present as an acute abdomen. Dr. Kavita has explained all that, differential diagnosis and everything. There are so many differential diagnoses. So it's not easy to deal with the acute abdomen cases. So before going to the cases, we like to do little homework. What is acute abdomen? It accounts for the 5 to 10% of the emergency department visits. The causes are obstetrics, gynecological, and many other which encompass the wide spectrum of the surgical and the medical condition. Acute abdomen in pregnancy is one of the most challenging situations in case of the diagnosis and management. pregnancy is a condition where a lot of anatomical and the physiological changes are going on. So intra-abdominal organs are displaced. They take different position. So there is a lot of challenges in diagnosis. This may result in the delay in the management and increase the maternal and the fetal morbidity and mortality. Certain studies have been done. It has been found that the diagnosis of acute appendicitis in 11.1%, acute cholecystitis 16.6%, acute pancreatitis in 16.6%, malrotation in 11%, uterine rupture in 11%. We used to see in medical college, but these days they're very uncommon unless a patient comes from periphery with misoprostol in previous cesarean cases. Rudimentary horn rupture in 22.4%, ovarian cyst torsion is 11%. The clinical presentation include pain abdomen only, pain abdomen and vomiting in 44% cases, pain abdomen in shock 39% of the cases. Dr. Kavita has very beautifully explained. We should see whether the patient is hemodynamically stable or not, and according to that we have to manage. The abdominal tenderness 33.3%. The diagnosis is confirmed with ultrasonography in 55%. 11% we require a magnetic resonance imaging MRI, and 33% are diagnosed on table. So physical findings are less prominent compared to those of the non-pregnant state with the same disorder. Diagnosis of acute abdomen is challenging, requires careful history, thorough evaluation of the symptoms, examination, truth of the investigation to specify the disease and management, which many times could be surgery only. Leading problem in the diagnosis of acute abdomen during pregnancy are expanding uterus, which displaces the other intra-abdominal organs and thus makes the physical examination very difficult. High prevalence of the nausea, vomiting, and abdominal pain is already there in pregnancy, and general reluctance to operate unnecessarily on the gravid uterus. So sometimes the diagnosis is delayed. So accurate knowledge is essential for appropriate and timely decision. Now we come to the case. The first case is, as we are discussing first case, and we will have elaborate discussion what to do, what are the differential diagnosis, how to manage, what is the action plan. And this first case, I think Dr. Anshu Kakkad will take. Anshu, are you ready to take this case?
Yes,
Everyone please listen carefully about the case. A 23 years old G2P1 woman of 16 weeks gestation presents to the emergency department complaining of 12 hours history of colicky, right lower abdominal pain. Anshu, are you listening?
Yes, ma'am, I'm there.
With vomiting. She denies vaginal bleeding, leaking of fluid per vagina. She denies diarrhea or eating stale foods. She denies dysuria or fever and has no surgeries prior surgery. She doesn't have any prior surgeries. Her vital signs include blood pressure 100/70, heart rate is 105, respiratory rate is 12 beats per minute, temperature, she's a mild managed temperature, mileage, and she's a 99 Fahrenheit temperature. On abdominal examination, her bowel sounds are hypoactive. Abdomen is tender in the right lower quadrant region with significant involuntary gardening. Cervix is closed. Fetal heart tones are in the range of 150 beats per minute. Anshu, what is your line of management? How will you proceed this case? And what things are coming in your mind?
Ma'am, as being told right from the MBBS, the moment we see right lower quadrant pain, so there is first thing that clicks is appendicitis only. And as you're telling that hypoactive bladder is also hypoactive bowel sounds are also there. So yes, it can be that. And then differential diagnosis can be among the UTI or ureteric colic can be there. So these are the differential diagnoses. However, bowel sounds will not be affected by it.
Absolutely right. The patient is stable, hemodynamic is stable. And in this particular case, we will go slowly and we'll evaluate everything. And I'm sure you are absolutely right. Investigation required is ultrasound. And so action plan is chalked. It is in the general care of the patient. As Dr. Kavita has told, review history, whether the woman is in reproductive age, we have to consider she is a 16-week pregnancy. General examination very important, and we have already mentioned, and we have to take the degree of distress. She is having mild mileage, and abdominal examination, presence of scar, gardening, rebound tenderness, pelvic examination, IV line is very important. And ultrasound we have to do. If she is in severe pain, we have to give analgesia, and we have to see if, what gestation age she is. She is in 16 weeks, so we can give opiates. And supplementary information is required. We have to see the nature of the pain, timing, radiation, and we have to exclude. In this particular case, she is 16 weeks. No, we can. So ectopic pregnancy is excluded. Shoulder pain is excluded, but in general, we have to see everything. An investigation required. General investigation, we have to do all the investigation, blood picture, amylase, abdominal X-ray, chest X-ray, abdominal ultrasound, and selective, we have to do grouping and matching ESR and C-reactive protein, whether it is ovarian cyst or appendicitis and any other problem, LFT, biliary disorder. Sometimes I've seen in patient with the gallbladder stone, instead of upper right quadrant pain, she used to complain pain in the lower abdomen. So the variation can be found in pregnancy cases. Fecal occult blood, CA125, and we have to see whether there is a need for laparoscopy or not. Differential diagnosis, Dr. Anshu has told already, it could be appendicitis, acute cholecystitis, ovarian torsion, placental disruption, abruption, ectopic. Less common is regeneration, but she's having pain in the lower abdomen, and it could be regeneration, but it's not localized. It is a rebound tenderness. I'm sure you have explained the differential diagnosis. So we need to be very careful in history, physical examination, and re-examination are the most important steps. So summary of this particular case is Anshu, 23 years old woman. She is 16 pregnancy. She presents with colicky pain. On ultrasound, she has got 9 centimeter ovarian cyst, abdomen that is tender in the right lower quadrant region and significant involuntary gardening. And when you see the 9 centimeter ovarian cyst, what diagnosis comes in your mind, Dr. Anshu?
Ma'am, since she's in acute pain and have a cyst of 9 centimeter, which is quite big in size, so ovarian torsion is the first diagnosis. And
absolutely.
Yeah.
Absolutely. And the line of management is, in this particular case, line of management, will you go for surgery? You will wait, you will give IV fluids, you will manage conservatively. If the pain is not relieved, then we have to go for laparoscopy. And most of the time, ovarian cysts present between the 14 to 16 weeks of pregnancy. So you have already told diagnosis torsion of the ovary. And what is the best treatment for this condition, Dr. Anshu?
Ma'am, she is in acute abdomen. So in that case, we'll have to do the surgery. And
absolutely right. Absolutely right. What will you do? What will you do? Surgery, you have done laparoscopy, you have seen the twisted ovarian cyst. What is your planning to do laparoscopically?
Ma'am, it can be done laparoscopically also, because she's just 16 weeks. We have to keep few things in mind. We should avoid putting a varus needle. Open laparoscopic entry should be done. We can do it, but until it's a surgeon's choice basically. Surgeon should be comfortable, and route should be chosen by the surgeon.
Very good. He's taken charge of the secretary of the Dehradun Society. She's busy all the time preparing for conferences and big things with Dr. Manisha. So absolutely right, Dr. Anshu, you have told the right thing. But one thing I will like to tell you, previously, people used to go when there is a torsion, there is a thrombus in the pedicle. We used to go for ovarectomy. We used to do salpingo-ovarectomy, but these days it's not the right thing. When you do laparoscopy, you untwist the ovary, and most of the time there is a perfusion do occur. Even the thrombus is there. We should do ovarian cystectomy only. We should avoid taking out ovary in such a young patient to preserve her fertility. So ovarian cystectomy is the best treatment in this particular patient. We come to the next patient now, and everyone listen. She is a 32 years old G1P0 woman at 29 weeks gestation, present with a one-day history of the severe mid-epigastric abdominal pain. Mid-epigastrial abdominal pain she is having. So radiating to the back and multiple episodes of nausea and vomiting. Dr. Anushri, are you ready to take this case?
Yes, ma'am.
Okay. On examination, her blood pressure is 100 by 60 millimeter Hg. Heart rate is 110 beat per minute. Temperature is 99 degrees Fahrenheit. Her abdominal examination has tenderness and diffuse rebound. The serum lipase and amylase levels are markedly elevated. So diagnosis is very clear by the history. Anushri?
Yes, ma'am. Ma'am, as it is a non-obstetric cause, first of all, plus we know that serum amylase and lipase levels are raised. So this is a case of pregnancy with acute pancreatitis.
Right,
And
absolutely right.
She's 29 weeks of gestation. So first of all, we have to admit this patient. And then in this, generally pancreatitis in pregnancy should be managed conservatively if possible. So first we will grade the pancreatitis. If the patient is having mild pancreatitis or moderate also, the best management would be conservative management. We keep her nil per oral, and we can give her IV fluids, of course, and parenteral nutrition or enteral nutrition if the pancreatitis is mild. And after a few days, the patient should respond. But it is important to, I would like to say it is very important to diagnose the cause of pancreatitis.
Right,
Because
absolutely right. Yeah.
mostly the most common cause is gallstone pancreatitis. So we have to make
Absolutely
sure
right,
whether it is gallstones are still okay. You can offer the patient cholecystectomy because she is in 29 weeks. We can offer her now she's third trimester. So if the patient is gallstone pancreatitis, so if the patient is having gallstones, common bile duct stones, we have to ask her whether she can we have to tell her that she can have episodes of recurrent pancreatitis because of this. And especially if you have very small gallstones, we might first we'll do an abdominal ultrasound, and that should be sufficient in diagnosing the gallstones. But CBD stones maybe might require endoscopic ultrasound or even ERCP if we are suspecting, if we are seeing that the pancreatitis is not responding to conservative management. And we can either do a ERCP also if it is indicated, because in third trimester and second trimester we generally don't go for cholecystectomy. However, it depends upon the surgeon. It is an early third trimester. You never know, they might a surgeon might prefer a cholecystectomy if he's suspecting repeated episodes of pancreatitis. If he's suspecting repeated
right.
episodes,
If the patient is not recovering, patient is not responding, and it is a recurrent type patient, most of the time they relapse do occur. They become most of the time normal. They by giving nothing by mouth. Surgery is inflamed pancreas, we avoid, and so we avoid delivery also. So
we avoid delivery also.
Is a very important thing in pregnancy.
The prognosis of acute pancreatitis is quite good in pregnancy, but we also should do the scoring, like the Ranson scoring. That is up to the surgeons and the physicians, to the surgeons and the emergency medicine people to do. However, if they suggest that pancreatitis is, you are suspecting a CBD stone, or you're suspecting sludge which is going to come again and again, or you're suspecting obstruction to the pancreatic duct, you can of course do a ERCP, you can do sphincterotomy, you can put a stent. That depends upon the gastroenterologist and the patient also. And one more thing I would like to add in pancreatitis is that when we manage pancreatitis, we have to see the level of calcium also. Because many a times, pregnancy is always a state of hypocalcemia. And in pancreatitis, there is always a decrease in calcium. So many a times patient can present with symptoms of hypocalcemia. So if the calcium level is less than 8, we should keep a very close monitoring and give calcium gluconate slow and monitor the calcium levels, very important, depending upon how long the patient stays with us. Yes, ma'am.
So very well explained, Dr. Anushri. It is very important. Common causes gallstones, and with the diagnosis of pancreatitis, the next diagnostic step include the assessment of the severity of the condition with Ransom criteria of hypoxia, hemorrhage, and complications and the renal insufficiency, and looking for the underlying cause of the pancreatitis. And
again, if
gallstones are found, the consideration may be given to the eventual cholecystectomy once the patient is stabilized. And you have very well told that the endoscopy, retrograde cholangiopancreatography with endoscopy stone extraction can be performed if there is bile duct, bile duct stone is suspected.
And ma'am, even the second most common cause is hyperlipidemia. So if there is hyperlipidemia, generally nothing needs to be done. However, the hyperlipidemia in the third trimester is very severe, causes very severe pancreatitis, but still the management is conservative. So the cause of pancreatitis needs to be ruled out, ma'am.
We have seen in cases of most of the time when the girls come in the second trimester, the mother-in-law and everyone feeded them with the high fatty diets. Because of that, the hyperlipidemia and they have cholestasis and they have all these problems are very common.
In these cases, generally, I read somewhere that we give insulin also because it causes increase in lipoprotein lipase, so which is very good for the management of pancreatitis of hyperlipidemia type. So,
okay, great.
And heparin, insulin and heparin, yes. Yes,
sugar pancreatitis will also derange sugar levels. That's why sugar.
Yes, of course, of course,
definitely.
Yes,
affects pancreas, inflammation of the pancreas.
Of course, if it's sugar levels,
pancreatitis, patient develop diabetes.
Yes,
they come with a DDM.
Yes, ma'am.
DDM. So it's very important. And 10 to 12% patient present with this problem in pregnancy. So now we come to the phase 3.
Excuse me, ma'am. Ma'am, in such cases, since in acute pancreatitis, the sepsis and all is very common and patient may go into shock, ABG is also very important. We should do a ABG of such patient at least to have an
that
the patient is not in
Kavita has very well explained everything in detail. So she has told that what is the hemodynamically stable or not stable, and we have to manage accordingly. So we come to the third case. Dr. Josna.
Yes, ma'am.
Please take this case and listen to it carefully. And 26-year-old G1 P0 woman of 18 weeks pregnancy complains of the 2 months history of the colicky, right abdominal pain when she eats. It is associated with the nausea and the emesis. She states that the pain radiates to her right shoulder. The patient has a family history of diabetes. And by reading the history, what do you see and how will you approach this case, Dr. Josna? What specific investigation you will do, and what is the most likely diagnosis, and how will you manage this case?
See, she's a primary patient and she has in like a second trimester, 18 weeks, but she's having 2 months history. What we are giving to every time she's eating the food, she's having gastric problem. She's having a typical nausea, vomiting, and colicky pain. So, and colicky pain, whatever it is, our first thing goes to stone. So if we see, then then gallbladder stones is very much associated, and the chances of having gallbladder stone, it increases in pregnancy. And we have to clinch the diagnosis, we have this line that you said, no, that the pain radiates to the right shoulder. That means there is irritation of the diaphragm and it is going to the shoulder. So with that, most likely the provisional diagnosis will keep gallbladder stones to maybe in a first diagnosis. And having this, and how to diagnose it, I think ultrasonography of upper abdomen, it will be the best non-invasive modality in clinching the diagnosis. So the investigation of choice will be ultrasonography. And if it's come out, and gallbladder, we know that in pregnancy, there are two things which is very much in favor. It predisposes pregnant women for gallbladder stones. One is the increased in estrogen content, which leads to more of formation of cholestrogenesis or cholesterogenic gallbladder stones. And at the same time, progesterone has the stasis effect, so it leads to increase in the sluggishness. And when the both thing combines, so the incidence it rises. In books, it is said that it is 20 to 30% rise in the formation of GB stones.
Right, absolutely right. The gallstone slash increases in pregnancy, and there
Yeah,
is
so
increased chances of the stone formation during pregnancy. Absolutely right.
So how to manage me? I will admit the patient, of course. Then I will give her hydration. That is important. Then she may be given antispasmodic and analgesic. That will help her ease the pain if she has come in acute episode of the pain. And then we can also give, she's a symptomatic patient. So of course the actual management will be at the laparoscopic, taking out the laparoscopic management of the GB stones, or will be the best thing for her.
Yeah, absolutely right. Dr. Brijwala, do you want to add something which Dr. Josna has said?
She covered everything, although the best time is to do surgical intervention 18 weeks, because this is the best time to do. Otherwise, if we are prolonging pregnancy with the hyperestrogenic state and all this, she's going to have pain, and the second trimester is the best time when we can do surgical intervention. And during surgical intervention, whatever we are convenient, better to do laparoscopically, because this time we are able to put port easily, and recovery is fast. And just one thing I want to add, the pressure of the gaze during insufflation, it should be, we have to do open Hassan technique for port entry, and vena cava compression has to be avoided, and gaze pressure around during insufflation we can keep up to 20, but during later part of the surgical we have to keep it up to 12 millimeter. And we should monitor CO2 by EtCO2 monitor in our multipara, and early mobilization and DVT prophylaxis. This is important during pregnancy. That's all I want to add.
So, absolutely right, Dr. Brijwala.
I have a question.
In pregnancy, you have already explained, Dr. Josna, in pregnancy condition is usually treated as a low-fat diet and observed until postpartum. Most of the time, when it is a mid-trimester and she is having repeated episodes of the pain and she is not able to eat properly, then it is good to do surgery, as Dr. Brijwala has told. But initial management of the symptomatic cholelithiasis include bowel rest, intravenous hydration, narcotics. Initially, we have to do all the things. Morphine should be avoided because it can exacerbate the biliary colic. Relapse of the biliary colic is common, and the incidence is 1 in 1,600 and 10,000 pregnancies. And symptoms we all know. Ultrasound, what we see in ultrasound, there is a thickening of the wall more than 3 mm, and it is highly predictive of the cholecystitis. Secondary findings such as the pericholecystic fluid is there around the gallbladder, and the hyperemia may also be helpful. However, common bile duct stones will often be missed on ultrasound. So MR cholangiopentography can be used as a second-line imaging modality. So, we all will be able to manage acute cholecystitis in pregnancy. So let us move to the next case. Now we come to the case 4, and 30-year female, G3P1A1 with 22 weeks pregnancy, came in emergency with malaise with vague periumbilical pain. Dr. Pawanpreet.
Yes, ma'am.
This case, you have to take this case, and
yes, ma'am.
she is having periumbilical pain radiating to the flank area and to the right lateral area. There was no history of the vaginal bleeding, leaking, and the contraction. Fetal movements were normal. Physical examination revealed generalized tenderness, guarding, and rebound tenderness were present. Bowel sounds were decreased. Patient had mild fever. So investigation, CRP was considerably raised, and WBC was significantly higher. It was around 21,000 cells per cubic millimeter. So what diagnosis comes in your mind? What are the differential diagnoses? And what imaging technique will you use, and how will you manage this case? Dr. Pawanpreet?
Ma'am, looking at the history, it seems quite probably a case of acute appendicitis.
looking at the history, starting off the pain from the periumbilical area, then moving on to the right iliac fossa, eliciting tenderness in the right iliac fossa, raised CRP, raised counts. But though I would like to mention here that raised CRP and raised total leukocyte count should be taken with a little caution here, because these are sometimes found normally in pregnancy as well. Though 21,000 is a little too high, but generally also the TLC and the CRP can be raised during pregnancy. But still, looking at overall thing, it most likely looks to be a case of acute appendicitis. And DD of acute appendicitis would always be Meckel's diverticulitis, or maybe ureteric colic, or some acute ileitis, any inflammation of the bowel in the right iliac fossa. Being India, ma'am, the very common cause when you suspect appendicitis sometimes turns out to be tuberculosis of the ileocecal junction. Right. My husband, and being a surgeon and working in a surgical hospital, I've seen it quite too often. But this looks to be appendicitis as of now.
Right.
And next was, ma'am, can I see the previous slide? The imaging modality. Ma'am, first we would like to go for an ultrasound. See, ma'am, the role of ultrasound in establishing the diagnosis of appendicitis is a little, tricky here. If we can very confirmatorily see a blind structure, a dilated structure, the thickness more than 6 mm, sometimes it goes up to 1 centimeter also, or maybe we can see localized free fluid around that appendix. We have to see between the iliac arteries, the psoas muscle, and the border of the pelvis. If all this is clearly seen, and clinically we are very sure that it is appendicitis, then we don't need to go for further imaging. But sometimes ultrasound will not give us a very clear diagnosis. Then we need to confirm our diagnosis by further this thing, because in pregnancy, it's very likely that we miss the diagnosis. And if we miss the diagnosis, we put the woman up for more risk of preterm labor, of spreading the infection, of if the appendix bursts, it will lead to peritonitis, which can have fatal complications for the fetus as well as for the mother. And sometimes we overdiagnose too. And if we overdiagnose and go for a negative surgery, that also has its own implications. That itself increases the incidence of preterm labor as well as the fetal loss, all the risks of anesthesia and surgery to the mother as well as the fetus. So if ultrasound is not giving a conclusive diagnosis, we should not waste time and go for further imaging. If MRI is available, I would like to do an MRI. But when we order MRI, we have to be very careful that we take an MRI without contrast. Contrast should be avoided when we are doing an MRI during pregnancy. And if MRI is not available, then as Madam suggested, a CT has its role, but then we have to ensure that it is a limited exposure. We don't need to go for a CT of the whole abdomen with long exposure. We should take as little exposure as possible, and again without the contrast, to confirm our diagnosis for the appendix. And management, after all this, if it is a confirmed appendix, it has to be surgery. And laparoscopy, it's 22 weeks, right? So laparoscopy would be my choice.
Absolutely right. You have explained everything, Pawanpreet. So let us go through the literature also. Acute appendicitis is the most probable diagnosis in this case, which you have already told. It is complicating 1 in 1,500 deliveries. Although it can occur in any trimester, they appear most of the time in the second trimester. Pregnancy is associated with a higher rate of perforation, and they are diagnosed late because of the other symptoms. Vomiting and all are also common. Sometimes pain is because of the colitis, because of the ulcerative colitis and other regions, likely to delay in the diagnosis. And the clinical manifestation diagnosis of appendicitis in pregnancy are similar to those in non-pregnant individual. Pain in right lower quadrant is the most common presenting symptom, as it was here, and periumbilical pain is very common. Regardless of the gestation age, fever and leukocytosis are less less reliable indicators of appendicitis in pregnancy, as Dr. Pavanpreet has told. The differential diagnosis you have already told: inflammatory bowel disease, Crohn's disease, ulcerative colitis, constipation, gastroenteritis, peptic ulcer disease, small bowel obstruction, pancreatitis. Sometimes ectopic pregnancy can we can confuse with this thing, appendicitis, but not in this particular case. Ruptured ovarian cyst, ovarian torsion, renal colic, pyelonephritis, and rare disorders which Dr. Kavita told: sickle cell crisis, pneumonia, and diabetic ketosis, and porphyria can come under differential diagnosis. So, role of imaging technique, you have explained in a very right way. Abdominal ultrasonography is recommended in pregnant patient suspected of having appendicitis, although visualization of appendicitis may be very difficult, especially if the woman is obese and the uterus is large. If clinical findings and ultrasound are inconclusive, MRI should be considered when available, because it avoids fetal exposure to ionizing radiation and performs well in diagnosis of the lower abdominal pelvic disorders. Routine incorporation of the MRI into evaluation of the patient with suspected appendicitis has reduced the negative laparotomy rate. It is very important to note, by half, without a significant change in the perforation rate. If MRI suggests appendicitis, surgery is indicated by CT imaging, and it can be used if MRI is not available. So management, it depends on the clinical judgment. Laboratory tests are not particularly useful other than to rule out alternative diagnosis. Delaying intervention for more than 24 hours increases the risk of perforation. When the diagnosis is relatively certain, appendicectomy can be performed through a muscle splitting incision over the point of maximum tenderness. However, when the diagnosis is less certain, or if there is a chance that the cesarean delivery may need to be performed, that it may be more prudent to approach the appendix through lower midline vertical or the paramedial incision. Laparoscopic appendicectomy may be performed safely in pregnant patients and considered in many to be the standard care in first half of the pregnancy. Unruptured appendicitis associated with fetal loss rate of 3 to 5% with little effect on the maternal mortality. But by contrast, the fetal loss rate in setting of the ruptured appendicitis is 20 to 25%. Preterm labor and the birth can also occur, especially if there is a peritonitis, but peritonitis is very rare. So by discussing all the cases, there are many causes of acute appendicitis. We will summarize here: acute pancreatitis, pain, abdomen, vomiting, epigastrium pain, symptoms, and diagnose: raised serum amylase and serum lipase, which we discussed in the second case. Management is conservatively, and in acute cholecystitis cases, pain in abdomen with right hypochondrial tenderness, ultrasound diagnose 100%. Conservatively managed surgery may be required in 66.7% and conservative management in 33%. And cholecystectomy is the right choice. In acute appendicitis, pain and abdomen, vomiting, right iliac fossa tenderness, and paraumbilical pain, ultrasound in 50% of the cases and MRI in 50% of the cases. Laparoscopic appendicectomy if it is present in the first half of the pregnancy. And intestinal malrotation, sometimes intestinal obstruction may occur. There is increased distension of the abdomen, and besides USG reveals gross fluid in the peritoneal with suspect of the uterine rupture. We have to mention all these cases here, but we cannot take all the cases, so we are summarizing these cases here. Uterine rupture, pain in abdomen, shock in 100% of the cases, history of the previous LSCS in 100% of the cases, and history of the MTP in a few percent of the cases. Ultrasound in 50% of the cases. On most of the time, on table diagnosis was made. We used to see patients in medical college. Nowadays, we don't see such patients very often. So laparotomy has to be done with repair of or cesarean hysterectomy. Rudimentary horn rupture, pain in abdomen and shock is present. Ultrasound can diagnose in 50% of the cases, MRI in 25% of the cases, and in 25% of the cases, on table diagnosis is made. So laparoscopy and hemihysterectomy is done, and we can see the good result. Ovarian cyst torsion, we have already discussed. Pain in abdomen with vomiting, ultrasound in 50% of the cases, MRI in 50% of the cases. And ovarian cyst with no evidence of the torsion on table, confirmed torsion on the table. Sometimes it is confirmed and it is confirmed on table. So elective LSCS with concurrent cystectomy is done in one woman, and emergency LSCS with partial salpingectomy in other group of women. This is the studies done in 2018 in one of the hospitals. Now we come to the case 5.
Ma'am, before we go to the next case, can I add one thing?
Something? Right. Sure, Pavanpreet.
Ma'am, regarding leukocytosis during pregnancy, while going through the literature, I came across a very interesting thing, that is neutrophil lymphocyte ratio, NLR, and platelet lymphocyte ratio. These are the two markers that are being studied very widely to confirm appendicitis during pregnancy. Because irrespective of the normal raise in leukocytosis, still the neutrophil lymphocyte ratio, if it is more than 4.4, it is more indicative of appendicitis, and more than 8 is certainly indicative of, complicated appendicitis, maybe a ruptured one. And similarly for the platelet lymphocyte ratio, if that is more than 135 or 36, something is the ratio, that again is more indicative. So these are two things which we have probably never studied, but these are the new things that are coming up and can help to diagnose during pregnancy.
This is a very important point to be noted by all. Thank you, Pavanpreet. And now we come to the case 5.
Just want to add one thing. Can I?
Yes, sure, Dr. Brijwala.
Like imaging techniques, sonography is the gold standard. If we can see, if we cannot see in the second trimester, we can do MRI. If it is not available, we need to do CT before doing any surgical intervention. But CT should be done with good, like more than 64 slice and lesser time of exposure. And there is evidence of only 0.1% risk of early childhood malignancy. So we have to consider and talk to patient, counseling, consent, everything we need to do. So if we are in dilemma, rather than opening blindly or putting scope, we can consider CT scan.
Right. Sure. We don't have a MRI, then it is good to consider CT in certain cases. So we come to the case 5. A 23-year-old G1P1 woman at 30 weeks gestation arrives to the obstetrics triage area complaining of a 12-hour history of the abdominal pain. Dr. Sonam, are you here?
Yes, ma'am.
Yes. Will you take this case?
Yes, ma'am.
Okay, sure. Then concentrate on the history. Its history is very important. A 23-year-old G1P1 woman at 30 weeks gestation arrives to the obstetric triage area complaining of a 12-hour history of the abdominal pain. She denies trauma, vaginal bleeding, or fever. On examination, her temperature is 99. She has a little mileage. Heart rate is 100 per minute. BP is 100/70. Her abdominal examination demonstrates normal bowel sounds. There is a point pain localized on anterior uterus, which feels irregular. Other parts of the abdomen are non-tender. The fetal heart rate is 140 per minute, and reactive without decelerations. There is no uterine contractions. So, by history, what is the probable diagnosis, Dr. Sonam, and what is your action plan?
Thank you, ma'am, for the case. Ma'am, can I start with my video? My video has been disabled. I'm not able to start with my video. Okay, ma'am, going forward with the case, as we can see of the patient is having mild inflammation.
You're not able to show your video, dear?
No, ma'am, it is showing disabled.
Oh, why?
No
But
problem, ma'am. We'll start as I think my mic has now been opened.
okay.
So, ma'am, as we can see with this patient, the patient is almost 30 weeks of gestation and her whole abdomen is normal. But in the there's a pinpoint tenderness and a localized irregular mass, as we can see in the patient. So it denotes some anatomical, like most common will be a fibroid uterus in this patient, because fibroids are there, though unlikely, but they may go for the sarcomatous changes or red degeneration, which is commonly caused for these patients. So we have to think in that action plan that a patient is having a fibroid. If we having any previous ultrasound available with the patient, we can check out with that.
Right.
Even though the patient was having fibroid
It's very
previously, as
important to
shown
have a
in the
prior
anterior wall itself, and
before
might be,
pregnancy. Yeah, right.
and we have to go for an ultrasound, ma'am, so that we can also know, and we have to do the complete blood count also for this patient, ma'am, so that we can also see the TLC and what is the HB level of this patient. And since this patient, actually patients mostly they come with acute abdominal pain, also with fever, and there may be a history of any nausea and vomiting, though it is not present in this patient. I would probably suspecting any fibroid uterus, which may has gone for any red degeneration, and I will like to proceed with the blood investigations and an ultrasound, ma'am.
Absolutely right. Absolutely right, Sonam. Absolutely right. So, ultrasound scanning is a primary modality of diagnosis and typically shows a fibroid corresponding to the area of the tenderness over the uterus. Most often, the degenerative fibroid has a mixed echogenic appearance. What happens in pregnancy? The fibroid grows, but the circulation doesn't grow. So there is a ischemic area and the pain do occur. So MRI we can do, where the sonography is inconclusive, we can do MRI. Abdominal MRI may be considered. In red degeneration, the typical finding is a uterine fibroid with increased T1 signal intensity. Absolutely right, Sonam. How will you manage this case?
Most commonly, ma'am, these patients should be managed conservatively. We should admit the patient and the hydration level should be maintained. Along with we can also start with broad spectrum antibiotics for any infection. Mostly the patients recover well, ma'am, and we have to avoid surgeries in this type of patient. It will recover well with the conservative plan of management itself, ma'am. We can also start with analgesics for these patients, ma'am. We start with the non-steroidal anti-inflammatory drugs because they're prone for inflammation also. And suppose if you're not getting relief with NSAIDs, we can go for opioids also.
Absolutely right. Dr. Brijwala, do you want to say something about this red degeneration of fibroid case in pregnancy?
Like she had covered that we need to do conservative management, but as in this case it was 30 weeks, so we are near term. We have to see about the complication associated with fibroid, like there may be placental abruption, so we need to look after the fetal monitoring very properly. And now I started doing one thing since 7-8 years. During NT scan I started getting whole abdomen sonography. So beforehand we need to tell the patient about if she is having fibroid, that there may be chances of increase in size, there may be chances of red degeneration, so they are aware and they can come to us in time. That's
absolutely right, Dr. Brijwala, which point you have mentioned, there are chances of abruption also in these patients. So this point is very important to be noted. By seeing all these cases, what we need to know, what are the indications for surgical management in the acute abdomen? We have to remember thin rim. T for torsion, H for hemorrhage, I for infection, as in appendicitis, cholecystitis, and other things, and ovarian abscess, necrosis, R for rupture, I for infection, and the M for malignant changes, and in the red, as in the red degeneration. We should know what are the indications for surgical management in acute abdomen. Thin rim, we can remember, and we can know what are these. Now we come to the case number 6. So this patient, we also encountered such patient a long time back in 2012, which I discussed. And since by the time I forgot the extensive study of my PG time, it didn't remind my mind it could be heterotopic pregnancy. Anyway, we need not to discuss what is it. Anyway, let us discuss this particular case. 25 years of old woman with amenorrhea of 6 weeks pregnancy came in the clinic with the pain in abdomen radiating to the shoulder tip, rectal discomfort, dizziness, and with the mild bleeding PV. On PV examination, uterus is enlarged with adnexal tenderness and tender cervical movement. Cervical movement was tender. Urine pregnancy test positive. Serum beta HCG markedly raised. On ultrasound and intrauterine gestation, this is the recent case we have seen of 6 weeks with yolk sac, fetal pole and cardiac activity visualized, free fluid in the pouch of Douglas with gestation sac and the fetus with cardiac activity visualized in right adnexa. Dr. Sonu?
Yes, ma'am. Yes,
will
ma'am.
you take this case? Should I repeat
sure.
the history?
No, ma'am, sure. You have already told the diagnosis also.
Okay, Dr. Sonu. So,
ma'am, it is a clear-cut
yeah, this
case
is the
of
clear-cut case,
yeah.
and this is the image of the transvaginal sonography of the uterus, showing an intrauterine gestation coexisting with the ectopic tubal pregnancy with a sac of 2.5 centimeter in diameter, containing an embryo with a crown rump length of the 13 mm. So, Sonu, what is your action plan for this case?
So, ma'am, in this case, since the patient is already in hypovolemic shock, she's already having intra-abdominal hemorrhage also, she's having distress, there is fluid, so she's having the referred shoulder pain also. In any case, this patient has to be stabilized, and side by side, we have to emergently manage for the surgical intervention. And the idea is to get rid of this abnormal pregnancy, and in 50 to 60% of the cases, the normal pregnancy continues in its own way. The supportive management, as we give as a post-surgical patient, we will be giving, and just resuscitate the patient, do the surgery as soon as possible, replace the blood if it is required according to the blood transfusion. I would say we should not do very aggressive blood transfusion unless and until required. So if there is a hemogram which is showing 5-6 hemoglobin, yes, I think then I would go only for 2 PRBCs if I'm able to solve the problem.
Right. Sonu, I would like to know, you have not done ultrasound, what differential diagnosis are coming in your mind?
So, ma'am, since there's free fluid, there is fluid in the abdomen, so it can be any kind of peritonitis. If it is not hemorrhagic, it can be any kind of peritonitis. So,
so DD is all these things which is mentioned.
All the patient, just
and
the only thing is that heterotopic pregnancy, which is having a very, the incidence is 1 in 30,000, has come down to 1 in 3,900 after ART and IVF. So, that is so any patient who is already having a history where you should have a high suspicion of heterotrophic, even if you are not able to diagnose on ultrasound, and if you are having a very high suspicion, patient had already had a history of ectopic, or she had a history of previous tubal surgeries, or she had PID, or she had undergone a IVF, then you should be more, prudent to diagnose heterotrophic, though the incidence is less, but yes, it has to be kept in the mind.
So absolutely right. DD you have told and diagnosed. You have diagnosed through ultrasound, and you have also told in 50 to 60% case, 60% of cases, the intrauterine pregnancy is very well maintained. So how will you manage this case?
Management. This patient has to undergo a surgery. This has to undergo a surgery. Right. Yeah, laparoscopy has to be done.
Yeah, and has to be done. Yeah. Absolutely right. So, in short, doctor must be alert to the fact that the confirming intrauterine pregnancy clinically or by ultrasound does not exclude the coexistence of an ectopic pregnancy that should systematically be suspected in any woman presenting abdominal.
Ma'am, moreover, the incidence of the diagnosis of heterotropic by ultrasound, the sensitivity is having a wide variation.
Very good.
There's 26% to 90%. That is on average only 56%. 56% of the cases will be diagnosed by ultrasound on average.
Right. Absolutely right. 26 to 92%. Very good. Absolutely right. So, so heterotopic pregnancy is very rare. One is 30,000, and now, as you have the recent studies, you are telling it is 1 in 39,000. And in ART pregnancy, its incidence is very high. I myself encountered in ART pregnancy, heterotopic pregnancy, and in spontaneous pregnancy, it is 1 in 30,000, 39,000, as Dr. Sonu has told. And higher prevalence may occur in assisted reproductive technique that may reach up to 1 case per 100 in some literatures. And pain with hypovolemic shock during pregnancy is common. And as you have already told about the ultrasound part, sensitivity is 26 to 92%. And management, the goal of the treatment is to preserve the viable intrauterine pregnancy and to remove the non-viable ectopic pregnancy through salpingectomy or salpingostomy. In case of an unruptured ectopic pregnancy, local feticide injection can be used to remove the ectopic pregnancy. For this method, ultrasound is used to guide the needle to the ectopic pregnancy, and substances such as the potassium chloride and the hyperosmolar glucose are injected directly into the gestation sac. The use of this method can be limited due to the location. It is not easy to inject because the mobility of the tubes, location of the ectopic pregnancy, and the experience of the physician counts a lot. Treatment of the heterotopic pregnancy will depend on the specific location of the ectopic pregnancy as well as the pregnant person, clinical presentation, and stability of the patient. Extrauterine pregnancy are non-viable and can be fatal to the mother if left untreated. However, the successfully continuing the intrauterine pregnancy following removal of the extrauterine is possible and has a success rate of about 50 to 66%, which Dr. Sonu has already told. And I've gone through the literature and I have found that many studies have been done, and the studies have been done in October 2020, and by Tamer Ali, they have found that the ectopic pregnancy is a rare condition. Any pregnant woman presenting with the alarming abdominal pain and actual abnormality, heterotopic pregnancy should be among the differential diagnosis possibilities, and the patient should be thoroughly investigated and using ultrasound and MRI if needed. If it excludes this rare diagnosis and allow on-time proper management. And one such case we found, the studies was done, it was a unique case of diagnosis of the heterotopic pregnancy at 26 weeks. Case report on the literature review, it was done by Anik Eddy in January 2021. In this case, no sonography looked for the adnexa. She used to come with a little pain and it used to subside. And at 26 weeks, they found there is a great mass. And so this is a rare condition they found at 26 weeks. Heterotopic pregnancy is a rare condition which at least 2 pregnancies are present. ये तो वही same बता रहे हैं, abstract बता रहे हैं about this pregnancy. What was the conclusion? So in this particular case, first trimester, there was an episode of the vaginal bleeding, and in 24 weeks, there was a threatening preterm labor. In 26 weeks, there was abdominal pain, and on ultrasound, they admitted and they found a good localized hemoperitoneum, and they diagnosed it. And it was operated laparoscopically. So this was the same slide Dr. Kavita has sent to me, and I think she has also put the same slide. So she has explained it very well. Dr. Brajbala, do you want to say anything regarding this heterotopic pregnancy?
Like previously we were taught about think ectopic. Now we should think about heterotopic pregnancy every time, even we see intrauterine pregnancy, because in the era of ovulation induction and many we are coming across, and we can manage very effectively, and the intrauterine pregnancy goes on till terms if we detect in time. So whenever patient complains of any pain or any spotting, we should do sonography and TVS sonography to rule out every time. We should not ignore any type of pain complained by patient.
Good to see Dr. Sangeeta Singhal. And this has been already explained by Dr. Kavita. And so we reach to the conclusion. Diagnosis and treatment of the acute abdomen in pregnancy should be individualized. Good clinical acumen is essential for ordering early diagnostic tests in acute abdomen in pregnancy. Appropriate intervention should be undertaken at the earliest to reduce the maternal and the fetal complication. Over to you, Dr. Sangeeta.
You're muted,
Dr. Sangeeta. You're muted, I think. Dr. Sangeeta, you're muted.
Okay. Good evening, ma'am. Good evening.
Good evening. Good to see you.
Okay. Oh, thank you, ma'am. Thank you. And Dr. Meenu, you have prepared a very extensive and this case studies with a very thorough, workup. And all panelists have participated very well and manage the case very well so that everybody is I mean, delighted to have this all diagnosis and management, and which should be very helpful, I think, in the day-to-day management. And regarding the CT scan, I want to just say that this 5 rads limit is acceptable to the fetal, I mean, teratogenicity. It should be less than 5 rad. And single CT scan exposure, it only gives 25, 25 milligray. 5 rad is equal to 50 milligray. So if we ask our radiologists to reduce it, they can reduce it up to 13 milligray by just targeted exposure. So this we have to keep in mind, and we have to discuss it with the radiologist. And MRI, as everybody suggests, that it is not giving ionizing radiation. It is true. But ma'am, it is giving sound pollution to the baby. Old MRI machines have caused fetal hearing loss due to the loud sound during the MRI.
Right.
So I think the new
I've
MRI...
gone through the MRI of my knees and I've heard how difficult it is to go through that machine.
And ma'am, these causes fetal hearing loss. So these have to be kept in mind before prescribing the MRI. It is also not because, without any complication.
True, absolutely right. It is not easy to go to MRI. But sometimes we need for the we can avoid appendicectomy, we can avoid the appendicular perforation. All these things we sometimes need.
Yes, ma'am. Written consent from the patient is very important in today's scenario to avoid the legal complication in future if the baby is having hearing loss after that. So I think I'm such kind of panel discussion.
Absolutely right. Dr. Sangeeta, very good input. And Dr. Brajbala, good to see you. Good to have you here. And
as expert panelist, ma'am.
Yeah, I was delighted. We had a wonderful panel. And thank you very much to Dr. Kavita. Dr. Kavita is the one who initiated us. And I was a little bit jittery for the panel discussion. And she sent me the last slide. See, this will explain everything. And we know how to manage hemodynamically stable and hemodynamically unstable, how to go through, how to, this makes us learn to all these things. So thank you, everyone. And thank you, Shield people. Thank you. And over to Dr. Ashna. Thank you, everyone. Ashna, where are you? You are my right hand. Without Ashna, nothing is possible.
Thank you so much, ma'am. Aapne thank you boli diya. I just have to officially thank everyone for joining the webinar. Thank Dr. Kavita and Dr. Brajbala. Baaki sab to ma'am ghar pe hai.
Thank you so much all Uttarakhand Society and Dr. Meenu ji, particularly adding me in expert panel of yours and your collection of cases. You covered everything in detail and it was revisited, and I was revisiting Uttarakhand. I visited 3-4 times that place. Beautiful place with lovely people. Thank you so much.
Thank you everyone. Thank you everyone.
Thank you ma'am. Thank you.
Almost on time, ma'am.
Almost in time. I think Dr. Kavita has left. She is very particular about the time part.
Ma'am, she had to deliver a lecture.
I think she has to deliver another lecture on health.
Yes, ma'am.
Health syndrome, she was saying. Yeah. Good to see Dr. Brajbala here. Good to see. So it was a nice thing. We were planning another webinar and you are here. All people are here. Are you contesting for some posts?
Yes, I am contesting for Foxy Infertility Committee chairperson because I'm doing infertility since long and I'm having Foxy Recognized Center, and my daughter is also with me. She is MRCOG and she completed her MS in 2018. So this is the free time for me to serve come into Foxy. So I will need help of you all. Thank you so much.
Okay.
Thank you, ma'am.
Good to see you. Good to see you. Thank you, everyone. Thank you. Thank you.
Thank you, doctor. Thank you.
Hi, Reena. Good to see you.
Hi, doctor.
I think it's time to say goodbye. Thank you, Chitrakala.
Thank you, Meenu ma'am. Thank you to you too also.
Bye.
Thank you, Anshu. Anshu, you were very busy.